Today we are going to discuss a new topic, that is potassium. Normal potassium level is 3.5 to 5.1 milliequiliters. Most common and abundant intracellular cation, that is potassium, and nerve action potential nerve repolarization occurs due to closing of sodium channel and opening of potassium channel. Nerve hyperrepolarization occurs due to closing of potassium channel. Foods high in potassium like bananas, avocados, oranges, dates, potatoes, and milk. Most of potassium reabsorption occurs at proximal convoluted tubule and secretion occurs at distal convoluted tubules of nephron. So there are two kinds of abnormalities we observe in potassium. That is, when a potassium level is less than the 3.5 milliequiliters, that condition we used to call it as hypokalemia. When serum potassium level more than 5.1 milliequiliters, that condition we used to call it as hyperkalemia. So the causes for hypokalemia is GI fluid loss, because maximum potassium present in GI fluids itself. So when does the GI fluid loss occurs? When diarrhea, and in case of vomiting, and in case of nasogastric suctioning. In these conditions, GI fluid will be lost along with potassium loss will be there, and that may lead hypokalemia. Diuresis, high aldosterone level, potassium wasting diuretics like diuretics and all, they will excrete more potassium through urine. Low magnesium will also help in increase potassium excretion. Sign and symptoms of hypokalemia, that is fatigue, weakness in muscle, early signs. These are early signs, and anorexia, nausea. Weak W indicates that weak, irregular pulse, cramps in leg, decreased bowel motility, hypoactive bowel sounds lead to constipation. Bradycardia, polyuria, postal hypotension, hyperglycemia. These are the conditions seen in hypokalemia. But along with ECG changes also we can observe, that is flattened or shallow T waves, ST segment depression, premature ventricular contractions, and prominent U wave appearance. And ECG wave, it appears like this. It's a slightly prolonging PR interval will be there, peak to P wave will be there, shallow T wave, and along with the prominent U wave will be there, and ST depression will be there. So this is the ECG, how it appears in case of hypokalemia. And the medical management we use here, IV or oral potassium replacement, and IV administration should be like very diluted form. It may lead sudden cardiac arrest and cardiac arrhythmia. Monitor closely for signs and symptoms of hypokalemia. Weakness and fatigue will be there. Never give potassium direct IV bolus. It may lead cardiac arrest. Administration of potassium chloride supplements when client is on loop or thiazide diuretics to prevent hypokalemia. Potassium given orally, encouraged to take with a full glass of water, promote absorption of GI tract. Teaching the client about food that which are high in potassium like banana, green leafy vegetables and all. Monitoring IV site for phlebitis and infiltrations. KCl is irritating to veins. Central lines are preferred site for IV administration. And hold KCl unless urine output is at least 0.5 ml per kg body weight per hour. Monitor ECG of the client for flat T waves, ST segment depression. Assess for sensitivity of digitalis and digoxin therapy if ongoing. That may lead toxicities. Thank you.